Welcome to ClearPath NCLEX, your clear path to nursing success. All right, everyone. In our last session, we finished up our discussion on magnesium. So today, we're moving on to the next critical electrolyte you absolutely need to know for the NCLEX, and that is phosphate. Let's dive right in. So here's our game plan for today. We're going to start with the basics, the phosphate fundamentals. Then, we'll look at what happens when it's too low, that's hypophosphatemia, and when it's too high, hyperphosphatemia. And then, we'll wrap it all up with what you're really here for, the high-yield NCLEX strategies to make sure you're ready for testing. Okay, let's start with Section 1, Phosphate Fundamentals. Getting a good grip on this makes everything else fall into place so much easier. So what exactly is phosphate? Well, it's a major intracellular electrolyte. That just means most of it hangs out inside our cells. Think of it as a powerhouse. It's essential for building our bones and teeth, and this is a big one, for creating energy. Now here's a key piece of the puzzle. Its levels are regulated by the parathyroid gland. And guess what else that gland regulates? Calcium. This is a huge hint that these two electrolytes are connected. Keep that in mind. So just how important is phosphate? Well, think of ATP, adenosine triphosphate. It's literally the P in our body's energy source. Without phosphate, our cells have no fuel. Simple as that. It's also a major building block for bones and teeth, helps keep our body's pH in balance, and it's needed for our muscles to contract properly. Okay, this is one of those numbers you just have to memorize for the NCLEX. The normal serum phosphate level is between 2.5 and 4.5 milligrams per deciliter. Now, in the real world, you'll always check your hospital's lab values, but for the exam, this is the range you need to know cold. All right, now that we have the fundamentals down, let's see what happens when these levels get out of whack. We're moving on to Section 2, Hypophosphatemia, which is just the fancy term for low phosphate. By definition, hypophosphatemia is simply when that serum phosphate level drops below 2.5. Remember, hypo always means low. So what can make phosphate levels drop so low? Well, a big one is hyperparathyroidism. When you have too much parathyroid hormone, it basically tells the kidneys to just dump all the phosphate. You can also see it in patients with malnutrition or those going through alcohol withdrawal. They just aren't taking enough in. Another classic NCLEX cause is refeeding syndrome, which you see with TPN, where the phosphate shifts from the blood into the cells. When you think low phosphate, I want you to think low energy. Everything gets weak and sluggish. Your patient is going to have profound muscle weakness, maybe some numbness and tingling, and decreased reflexes. But here is the major safety alert. This weakness can affect the respiratory muscles. This can lead to respiratory failure, and that makes it a life-threatening priority for you as the nurse. So, as the nurse, what are you going to do? Well, if it's a mild case, we can encourage foods that are high in phosphate. But for severe cases, we'll need to give IV phosphate replacement. And you have to do this slowly and carefully. Your number one job is to constantly monitor that patient's breathing and muscle strength. And because of that inverse relationship we mentioned, you're also going to be watching their calcium levels like a hawk. Okay, let's flip the coin now and move into Section 3, hyperphosphatemia, or you guessed it, high phosphate. And just like you'd expect, hyperphosphatemia is when that serum phosphate level creeps up above 4.5 milligrams per deciliter. Hyper means high. Now, this is a huge NCLEX topic. The number one cause of high phosphate is chronic kidney disease. When the kidneys fail, they can no longer excrete phosphate, so it just builds up in the blood. Other causes can be hypoparathyroidism, not enough hormone to get rid of phosphate, or when a lot of cells break down at once, like in tumor lysis syndrome, releasing all that intracellular phosphate into the blood. Okay, this is a massive NCLEX tip, so listen closely. The signs and symptoms of high phosphate are almost identical to the signs of low calcium. Why? Because when phosphate goes up, it binds with calcium in the blood, effectively pulling the calcium level down. So you're going to see things like muscle cramps, tetany, and positive Chustic's and Trousseau's signs, all the classic signs of hypocalcemia. Our management goals are to get that phosphate down and keep the patient safe. First, we'll restrict phosphate in their diet. Then we give medications called phosphate binders, which act like little sponges in the gut to grab onto phosphate so it gets passed in the stool. And because the low calcium puts the patient at risk for dangerous heart rhythms, you are absolutely going to put them on a heart monitor and watch that ECG. In severe cases, they may even need dialysis. We've covered the basics, the lows, and the highs. So now let's pull all of this together in our NCLEX strategy and review section to make sure you are ready to crush those exam questions. If you only remember one single thing from this entire lesson, let it be this. Phosphate and calcium have a critical inverse relationship. Think of them like they're on a seesaw. When one goes up, the other goes down. Understanding this one concept is the key to unlocking almost every NCLEX question about these two electrolytes. So let's review our pro tips. If an NCLEX question gives you a wacky phosphate level, your first thought should be, what's happening to the calcium? If you see a patient with chronic kidney disease, you should immediately think high phosphate. If the main symptom is muscle weakness, especially respiratory weakness, you better be thinking low phosphate. And always, always remember, the signs of high phosphate are the signs of low calcium. Okay, let's put this to the test. Question number 1. A nurse is caring for a client with chronic kidney disease. Which electrolyte imbalance should the nurse monitor for most closely? Take a second to think it through. The correct answer is hyperphosphatemia. The rationale is simple. Healthy kidneys get rid of phosphate. Kidneys that are failing can't. So in a client with CKD, that phosphate level is going to build up. All right, let's try one more. A client's lab results show a phosphate level of 1.9 milligrams per deciliter. Which clinical finding would the nurse anticipate seeing? And the answer is muscle weakness. A phosphate level of 1.9 is critically low. Remember our key concept, phosphate equals power. When phosphate is low, ATP production is low, and that directly leads to muscle weakness. Your priority assessment here would absolutely be their respiratory status. So, to lock this in for your exam, let's use some easy memory tricks. Think, phosphate is for power and energy, low phosphate leads to limp, weak muscles, and high phosphate put your patient at a high risk for low calcium tetany. So, whenever you see a phosphate question, the first thing you should ask yourself is, how does this affect my patient's calcium and their overall safety? Like, share, and subscribe to ClearPath NCLEX for more high-yield nursing content.